Mrs. J is a 63-year-old lady who presented to the emergency department with reduced consciousness. She has had diabetes mellitus for the last 20 years and is on oral medications. On arrival, her capillary glucose level was 2.6 millimole per liter. After infusion with dextrose, her glucose level increased to 5.2 millimole per liter and she regained consciousness. Her HbA1c was 5.4%. Her liver and renal function tests were normal.
Mrs. J's diagnosis is medication-induced hypoglycemia due to her low blood capillary glucose upon presentation, which is below 3.9 millimoles per liter, which is indicative of hypoglycemia. Her response to dextrose confirms that her lively presentation was a hypoglycemic episode, and due to her long duration of taking oral medications for diabetes mellitus, could have been the likely cause of her hypoglycemic episode. Her low HbA1c also indicates that there is a good glycemic control or recurrent hypoglycemia episodes, and her normal liver function and renal function exclude any causes of liver failure or significant renal impairment which may have contributed to her hypoglycemia.
The most likely cause of her condition is her oral medication. Normally, the target of HbA1c in diabetic patients should be less than 7. Given her HbA1c of 5.4 shows an overly tight regulation of her diabetes that leads to hypoglycemia.
One of the long-term implications is increased risk of injuries and falls. Hypoglycemia will lead to confusion, dizziness, and weakness, making falls more likely, especially in older adults. They have lower bone mass. This could lead to fractures, head injuries, and also loss of independence over time.
Another long-term implication of drug-induced hypoglycemia in type 2 diabetes mellitus patient is the increased risk of cardiovascular event. Hypoglycemia can trigger sympathetic nervous system activation, leading to the increased heart rate, blood pressure, and myocardial stress. Over time, this may contribute to arrhythmia, myocardial ischemia, as well as cerebrovascular events like stroke.
So the next effect of hypoglycemia is cognitive decline. So the brain relies entirely on the constant stream of glucose for its nutrients. So when you have hypoglycemia, you have less of that. So the brain, when this happens repeatedly, this will cause damage to the brain cells, which is the neurons, and affect cognitive functions such as memory, attention, and problem solving.
DPP-4 inhibitor should be used for Mrs. J to help her control her blood sugar levels because it does not cause hypoglycemia and it does not pose a risk for bone fractures. Besides that, DPP-4 inhibitors does not cause any liver or renal failures.
For elderly patients with diabetes and good renal function, metformin is one of the best antidiabetic agents because it can manage the blood glucose level without imposing hypoglycemia risk. Plus, it is widely accessible and affordable, making it suitable for Mrs. J.
Another alternative drug will be SGLT2, such as empagliflozin. It acts by inhibiting the reabsorption of glucose by kidney, and it also reduces the risk of heart failure.